Hi guys, my name's Lauren. I'm going to talk to you about cystic fibrosis today. Um, so a little bit why I chose to talk about cystic fibrosis is so it does run in my family. My mom happens to be a carrier of cystic fibrosis, and she actually had a brother with cystic fibrosis as well. So it's something that runs in my family, something I've already known a little bit about. So I really enjoyed researching it and really looking into the genetic component of things. So I'll start with a little bit of background. I'm sure you all have heard of it at some point. I'll refer to it a lot as CF throughout the presentation, but it's an autosomal recessive genetic disorder on the CFTR gene. It causes disease of the exocrine glands, which make mucus and sweat. It affects many organ systems, however, it mainly results in chronic respiratory infections and pancreatic enzyme insufficiency. Pulmonary involvement occurs in 90% of patients, and it causes mucus to become thick and sticky. It clogs the lungs, which actually harbors a place for bacteria to grow, causing a lot of recurrent respiratory infections and pneumonias. So over time, this can also cause pulmonary fibrosis, deterioration, and eventually respiratory failure. We do have a lot of advancing technology now, so lung transplants are really a thing, and we're doing a really good job of even preventing it from getting to that point. So also a little bit more about the history of it. So I found online that references have been found dated back to 1595 that have linked salty skin and damage to the pancreas with death in childhood by infants who were otherwise cursed or like bewitched, which was interesting. Um, Also interesting that it was only in 1938 that the first American pathologist, Dr. Dorothy Anderson, provided the first official description of cystic fibrosis in medical literature. She called it cystic fibrosis of the pancreas after her autopsy findings of children that died of malnutrition. And then in recent years, a lot of public awareness has increased significantly. A variety of organizations were formed in the 50s and 60s to educate patients and the public about CF. So it's really only been in the last like 50 to 70 years that we've really started advancing our technology on it and really becoming aware. So, cystic fibrosis is the most common lethal hereditary disease in the Caucasian population. What I found astonishing was approximately 1 in 29 Caucasian adults are carriers of CF, so that's a pretty big statistic. It does mainly affect white people of Northern European descent. So just to give you an idea of how frequent compared to the other ethnicities, it's one case per about 3,200 to 3,500 population in the Caucasian population. Hispanics are about one case per 9,200 to 9,500. African Americans have an even decreased risk, and Asians have an even more decreased risk. As you see on the slide there, it's for African Americans, one case per 15,000 to 17,000, and Asian Americans, one case per 31,000. So what I found interesting about this is, I knew about cystic fibrosis from my family history from it. But in my medical career in nursing, I have only taken care of one patient with cystic fibrosis. I don't take care of like a pediatric population. And it was a Latino girl, so I found that interesting. I've never really taken care of a Caucasian person with cystic fibrosis. So, a little bit about the clinical presentation. So, the median age at diagnosis is usually 6 to 8 months in infancy, and then over 2/3 of patients are diagnosed by age 1. Neonates typically present with meconium ileus and frequent poorly formed, foul-smelling stools, which suggests malabsorption. So, like the fatty stools. Respiratory manifestations include wheezing, coughing. I was reading that typically the coughing can start as like a dry hacking, and then it typically progresses to like a the sputum production, and the child may also have recurrent respiratory infections. It's usually caught nowadays during genetic testing or during newborn screenings. So on physical exam, I just kind of put this slide in there in case anyone goes into pediatrics and curious about what you would find on a physical exam. So examination of the nose and sinus cavities would reveal rhinitis or nasal polyps. Pulmonary system findings would include tachypnea, respiratory distress with retractions, wheezing, increased chest diameter, clubbing or cyanosis, and a hyperresonant chest upon percussion. So GI tract findings, you would find abdominal distension, bloating, hepatosplenomegaly, rectal prolapse, and some dry skin. And then other body system findings would include scoliosis or kyphosis, which has to do with the development and malnutrition portion of it, or swelling of the mandibular gland or parotid gland. So for diagnosis of cystic fibrosis, so the diagnosis of CF is typically based on pulmonary manifestations, GI tract manifestations, a family history, and then I don't know if you guys have heard of it, but there's the positive sweat test results. So genetic testing is available for people with a known family history. This test is highly specific and represents about 98% of mutations responsible for the disease. So newborn screening for CF is universally required in the United States. We use the immunoreactive trypsinogen or IRT as the primary screening. And high levels of IRT, which is a pancreatic protein in newborns, suggests CF, but it does warrant for DNA testing to make the official diagnosis. And then the sweat chloride test has to also be above 60, along with other symptoms like COPD-related symptoms, documented exocrine pancreatic insufficiency, or a positive family history. So a little bit about the actual genetics. So as I talked about earlier, it's an autosomal recessive disorder. So both parents have to be carriers in order to pass it off to a child. Each child has a 25% chance and 50% chance of becoming a carrier. So the gene responsible for cystic fibrosis is the cystic fibrosis transmembrane conductance regulator, or otherwise known as CFTR. There are about a lot of CFTR mutations that have been identified. I found a number online, 1,893. The CFTR functions normally as a chloride channel, and it's regulated by cyclic adenosine monophosphate, or CAMP. So mutations in the CFTR gene result in abnormalities of the CAMP-regulated chloride transport across epithelial cells on mucosal surfaces. So there are 6 documented classes of defects that result from these mutations. So it's either a complete absence of the CFTR protein synthesis, defective protein maturation and early degradation. This is the most common mutation. And then disordered regulation of diminished ATP binding and hydrolysis, and defective chloride conductance or channel gating. Diminished transcription due to promoter or splicing abnormality, and the last one is accelerated channel turnover from the cell surface. So all of these defects are kind of going to determine the severity of cystic fibrosis, which I'm going to go into on the next slide here. The CFTR mutations are known to have poor penetrance, so the genotype doesn't predict the pattern or severity of the disease. So a lot of people, you don't have to have the most aggressive form of CF, which would be the respiratory complications. You may only have, if you had CF, you may only deal with the malabsorption side of things. So it kind of depends on the defect. But a defective CFTR results in decreased secretion of chloride and increased reabsorption of sodium and water across epithelial cells. So basically, this results in sticky, thick mucus that's more susceptible to bacteria adherence, like I talked about earlier. So it leads to infection and inflammation. Secretions in the respiratory tract, GI tract, pancreas, sweat glands, and then other exocrine tissues therefore have increased viscosity, which makes them difficult to clear. So that's basically the management that we're talking about here. So that's my next slide. So the primary treatment goals of CF are maintaining lung function as close to normal as possible by controlling mucus secretions and preventing respiratory infections. For the young patients with CF as well, nutritional support is very important for their bone development and just for their all-around growth development. So you want to give them the enzyme supplements, multivitamins, mineral supplements. High energy, high fat diets are recommended. And I was also reading online, I didn't put it in my slide, that if you live in hotter climates, they recommend a diet high in salt because if you live in a hotter climate, you're sweating more, therefore your sodium is going to be depleted. And then obviously the main goal is managing and preventing complications and reducing hospital admission. So you want to control the disease like any chronic illness and really prevent from getting to the point of lung transplants. So mild pulmonary exacerbations can be managed at home. You increase the frequency of airway clearance via chest PT. A lot of patients with cystic fibrosis will have their own vest. Inhaled bronchodilator treatments, postural drainage, oral antibiotics for infections, and increasing the dose of a mucolytic agent, Dornase alpha. Other medications used to treat and manage CF include pancreatic enzyme supplements, multivitamins, mucolytics, nebulizer bronchodilators, and antibiotics, anti-inflammatory agents, and then agents devised to potential reverse the abnormalities in chloride transport. I was reading a little bit about those medications online. I didn't put it in the slide because they're fairly new medications, and they're not really proven to work. Well, they do work, but they're not really proven to control the disease any better than these other medications. So ethical considerations. So there's obviously the genetic testing, choosing to have a child with known cystic fibrosis. So, or when both parents are carriers. So my mom was kind of telling me that she knew she was a carrier, and the genetic testing back like 30 years ago wasn't as good as it is now. So she did want my dad to get tested because, she went through a lot of traumatic stuff with her own family, and she did not want to ever give her children the opportunity to have cystic fibrosis. So she really knew that, like, if my dad was a carrier, they would have to make a decision, which can be tough. So kind of the ethical implications on choosing to reproduce or not reproduce. And then I had found an article about the changes in life expectancy. So over the last, I would even say 10 years, the life expectancy of someone with cystic fibrosis has increased dramatically. So we have a lot of technology now that can control the disease. It's not as fatal as it once was. So there's also new technology such as the lung transplant. So that's just a lot to think about. So that's what I have to say about cystic fibrosis. I'm sorry if you guys couldn't really hear me that well. My speaker on my computer is pretty low. I tried to speak as loud as I could. Here are all my references, a lot of good articles, and I'm looking forward to hearing all of your presentations as well. So thank you.